Hello everyone, welcome back to my channel Lively Life Snippets. Today I would like to share a case which I encountered during my work in health clinic setting. It is about direct-acting antiviral, or in short, DAA initiation in a patient who was treated for hepatitis C and had underlying conditions such as chronic kidney disease, hypertension and gout. Please note that any content of this video does not substitute professional medical advices. If you have any health issues, please stick to your doctor and healthcare team. Kindly refer to the local protocols as well. Hepatitis C is an infection of the liver caused by an RNA virus. The virus belongs to the Flaviviridae family, and they have envelopes which surround them. There are 6 genotypes of virus available. In Malaysia, the most common genotype is genotype 3, which causes 61.9% of hepatitis C infection, and then followed by genotype 1, which causes 35.9% of all cases. Our Ministry of Health has established a new guideline called Management of Chronic Hepatitis C in Adults last year in 2019. This guideline suggests that all hepatitis C patients with confirmed viremia should be initiated with direct-acting antiviral within a year. Sustained virological response 12 is defined as undetectable HCV RNA at 12 weeks after treatment ends. It is considered equivalent to cure for hepatitis C infection. If hepatitis C virus RNA assays are not available, sustained virological response 24 can be checked by testing HCV core antigen at 24 weeks post-treatment. This slide shows the direct-acting antivirals available in Malaysia. In my clinic setting, only sofosbuvir and daclazatazil are available. Sofosbuvir is NS5V RNA-dependent RNA polymerase inhibitor, while daclazatazil is NS5A inhibitors. So, how do direct-acting antivirals work? First, the hepatitis C virus complex enters the hepatocyte by fusion. It then uncoats its outer membrane. After the positive HCV RNA strand has been transcribed by ribosomes to form hepatitis C virus polyprotein. This polypeptide is then cleaved by protease to form non-structural or NS proteins. There are 5 types of non-structural proteins, which are NS3, NS4B, NS5B, NS4A, and NS5A. Sofosbuvir inhibits NS5B RNA-dependent RNA polymerase, while daclazatazil inhibits NS5A proteins to prevent the conversion of negative HCV RNA strand into a positive HCV RNA strand. This further reduces viral replication, assembly, and release out of the hepatocyte. Let's start our case presentation. Our patient was Mr. HC, who is a 62 years old Chinese gentleman who has no known food and drug allergies. He is retired and currently living with his family members. He stopped smoking and drinking 1 year ago. He was being diagnosed with CKD stage 3A, hypertension, dyslipidemia, gouty arthritis, angina, and benign prostatic hyperplasia before this. He first visited the clinic in 2016 and was prescribed telmisartan tablets 80 mg once a day and amlodipine tablets 10 mg once a day for high blood pressure. He was also prescribed colchicine 1 tablet when needed for gout. He was started on aspirin 75 mg once a day to reduce the risk of cardiovascular events. Atorvastatin 20 mg once a day for dyslipidemia, and sublingual glyceryl trinitrate tablets, 1 tablet when needed for chest pain. 2 months later, he was started on terazosin tablets 1 mg at night for benign prostatic hyperplasia. In the next year, he was started on ranitidine tablets to relieve gastric, and upon product recall, it was stopped. Aspirin tablets was being switched to Casprin tablets, which trigger less gastric symptoms. A month later, he was started on allopurinol tablet at a dose of 100 mg daily for gout. He denied any consumption of over-the-counter products, supplements, herbal remedies, or natural products. HCV RNA shows 5,341 units per ml, and it is expected to fall below undetectable level 3 months after direct-acting antiviral treatment ends if the treatment is successful. In terms of liver function tests, the ALT and AST were higher than the normal range. Platelet count was normal. APRI is one of the non-invasive methods of assessing fibrosis which have been developed to reduce the need for liver biopsy. After we put in the value of AST and platelet count, we can get a score of 0.4. This is less than 1.5 and hence highly suggestive of non-cirrhotic stage. According to the guideline recommendation number 6 and 7, for patients like Mr. HC with confirmed viremia and non-cirrhotic liver disease, the combination of sofosbuvir 400 mg once a day and daclazine 60 mg once a day is suitable. The treatment is planned to start on the 28th of May in 2020 and it will last for 12 weeks and expected to end in the 18th of August 2020. According to the guideline recommendation 6 and 7, for patients like Mr. HC with confirmed viremia and non-cirrhotic liver disease, the combination of sofosbuvir 400 mg once a day and daclazine 60 mg once a day is suitable. The treatment is planned to start on the 28th of May 2020 and will last for 12 weeks and expected to end in 18th of August 2020. What is the latest creatine clearance for this patient? By using Cockcroft-Gault formula, Mr. HC creatine clearance is 59.4 ml per minute and should be classified under stage 3A. He is not on dialysis yet. The first pharmaceutical care issue encountered was a query I received from the prescriber. Can patients with renal impairment take direct-acting antivirals? According to the Hepatitis C guideline published in the year 2017, patients with mild to moderate renal impairment with an eGFR of at least 30 ml per minute per 1.73 meters square should be treated as the general recommendations. No dose adjustment are needed for both sofosbuvir and daclazine, but careful monitoring is suggested. Hence, our patient, Mr. HC, can be started on direct-acting antiviral. What are other factors we need to consider before we start the treatment? We need to check if the direct-acting antivirals will interact with the medication that the patient is taking currently. When possible, an interacting co-medication should be stopped for the duration of hepatitis C treatment or substituted with an alternative with less interaction potential. Interaction can be checked using the Liverpool HepIChart app. This app with the logo spiral shown can be downloaded from the Google Play Store. Be careful not to download the wrong app like what I did before. I had keyed in the intended direct-acting antivirus and concurrent medicines into the app, and the result triggers 3 potential interactions which will be discussed in detail in the following slides. The first potential interaction identified is daclazazine and amlodipine. Amlodipine may inhibit cytochrome 3A4 and subsequently increase daclazazine concentration. Use with caution. The prescriber decided to off amlodipine and start bisoprolol tablet at a dose of 2.5 mg once a day. Telmisartan is continued as there is no potential interaction. The third pharmaceutical issue is the potential interaction with atorvastatin. Daclazazine may inhibit OATP 1B1 and BRCP and consequently augment the atorvastatin concentration. Liverpool suggests to use with caution. The specialist decided to off atorvastatin and perform liver and kidney function tests in 3 weeks' time. Mr. HC will come back and consult doctor a month later. The fourth issue is potential interaction with colchicine tablets. Daclazazine may inhibit P-glycoprotein and result in higher colchicine concentration. Concomitant administration is not recommended in patients with renal impairment like our case here. Therefore, colchicine was off and allopurinol was continued. Another potential issue is contraception. Malaysia guidelines suggest patients on direct-acting antivirals should be counseled to avoid pregnancy during and 6 months after treatment ends. This applies to both female patients and female partner of male patients because there is lack of safety and efficacy data of direct-acting antivirals in pregnancy. For this patient, Mr. HC may start to have baby after mid-February in the following year if he wishes to. Make it clear to the patient that after this test can start become pregnant, not giving birth, to avoid miscommunication. The plan on first visit is to perform pill counting on next visit on 24th of June 2020 and check if Mr. HC is having any side effect. After a month, patient returned with correct pill count and claimed compliant. He did not experience any side effect. His blood pressure was high with a systolic blood pressure of 155 mm mercury, and the prescriber started him on prazosin tablet at 1 mg twice a day. The two main take-home messages from this case are: firstly, before the initiation of direct-acting antivirals, kindly check direct-acting antivirals interaction with disease states and drugs. Secondly, it is vital to encourage patients to be compliant to treatment to achieve sustained virological response at 12 weeks. Here is the list of references, and you are welcome to read further if interested. Thank you for watching Lively Life Snippet. Comment below on what type of content you would like to see from my channel in future. If you like my video, hit the like and share button. Don't forget to subscribe, and see you all in the next episode.